Okay, how many people here have used plasma? Okay, a few. I mean, this is really neat, different technology. That's really what it comes right down to. So I'm going to talk about sort of where we are and where we're going and how this fits into ours and people's practices who use this machine. First of all, it is unique. It's different. It's not a laser. It's not a light source. We can see collagen remodeling and tightening from this. It goes up to 2 years, so it's for a long period of time. You can do this stuff and be pretty aggressive or not aggressive at all, and yet you've got this natural biologic dressing that's on the skin. And as Fitz alluded to, there's just a versatile range of treatment protocols that we can use depending on how aggressive you want to be, and yet it's with one machine. So for those of you who haven't used it, it is really different because you don't see any laser light source here. There's nitrogen gas, which ultimately leads to this plasma, which leads to a thermal effect on the skin. So it's a totally different mechanism of producing heat within the skin, and the details are only going to bore you, so we'll skip it. And what you get out of that heat, induced by portrait plasma resurfacing, if you will, is this inner zone of thermal damage and an outer zone of thermal modification. So you've got heat there, yet you're leaving on this biologic dressing. This is the machine. Let's see if we can get this laser pointer to work. Yeah. This is actually the plasma coming out of it. It's a very simple machine. It looks cute. It's small. It's very portable. Easy to plug into the wall. And this is it. So you're actually not touching the skin at all. There's no actual touching to the skin. Goes very fast. And what you're doing to the skin is going to be totally dictated by the energy that you're choosing, which can be anywhere from a half a joule up to 1, 2, 3, or 3.5 or so joules. So it's a pretty simple technique. And the reason why this technology all of a sudden, because it's not that new, but all of a sudden it's becoming very exciting, is that the whole pendulum with what we're trying to accomplish, and you can see if you go around the different booths at the meeting, the whole pendulum is swinging back with patients wanting to see some results. We went from laser resurfacing, which worked, but had all of its problems, to non-ablative lunchtime procedures, which were easy to do but didn't do much, and people want to see results. So with plasma, you can effectively treat both cosmetic things. You can remove AKs. You can treat the whole skin architecture. And you can easily combine it with other things. So whether that's radiofrequency type stuff like thermage or other type tightening procedures or fillers or botulinum toxins, it sort of gives you the whole approach. It is FDA cleared for treatment of rhytids, actinic keratosis, and benign skin lesions of the skin. You can see tightening on top of that. So you've got something that can produce essentially resurfacing without ablating the epidermis and yet gives you tightening. And you can also see improvement in acne scars and lines. A lot of study data, so this is not something new, as I said. I think the interest in it all of a sudden is ballooning, but it's not new. The clinical data is now from over 600 study treatments, over 5 years of follow-up. And what's kind of interesting is to have this much 5-year follow-up and yet no scarring or hyperpigmentation being reported as long as recommended protocols are used is pretty nifty. Not a laser light source, so it's non-chromophore dependent at all. And generally we treat Fitzpatrick's skin types 1 through 4. So it's an in-office procedure which you can treat either on the full face or, equally as important, you can target certain areas of the body. There have been no lines of demarcation noted. You can use topical anesthesia. You don't need to have IV sedation. Local blocks or tumescent, either way is fine. You get rapid healing. Erythema is not long-lasting in this case. And as I said, you can see neocollagenesis up to 1 and then 2 years out. And what you see when you're treating, this is high energy. This is really at the peak, 3.5 joules. Yet you see the epidermis stays, and you get this vacuolization that occurs within the epidermis. And then if you look at people at day 4, what's happening is the epidermis is kind of lifted off. So it kind of flakes off with this new zone of epidermis, this new stratum corneum, that's under that line of cleavage, which is the regenerated epidermis. So that's where that natural biologic dressing is there. And here you can see at 10 days, again, this is following high energy. You can imagine with low energy, the epidermis really stays intact. At 10 days, you've got a fully regenerated epidermis with residual activity there, with intense fibroblastic activity, which is what leads to that new collagen formation that continues on and on and on. As I said, you in a sense could use high energy here and produce an effect of a carbon dioxide laser in reality, even though the epidermis stays on. But what's unique is you can do that, but you can also go all the way down to 1 and now 1/2 joule. So you can kind of do whatever you want. If someone wants to have more treatments and less of a wound, you can treat them somewhere around maybe 1.5 joules. If they want to have a really lunchtime type procedure, it's 1/2 joule. If they want to just get it done and get great results, you can treat them at 3 to 3.5 joules. And the histology correspondingly will be different depending on the energy you're going to use. So here you can see at 1 joule, and then 2.5 and 4. But in every situation, the common unifying theme is that epidermis stays intact. It is a non-ablative procedure even at high energies, which has led to a bunch of different protocols that now can be used to treat the whole spectrum. There's 6 different protocols that are used depending on the severity of sun damage, the severity of wrinkles, skin types, what you want to accomplish, and what you want in terms of recovery time. Very low energy, it's 1/2 joule over multiple treatments. This is really the classic lunchtime procedure for improving skin quality, to what's called PSR1, which is low energy, multiple treatments. So this, instead of being a 0.5 joules, will be roughly 1 joule and done over 3 treatments with great results and really no downtime, but done over a few treatments. Or for those people who want to be more aggressive and will take a little bit of downtime, either single or more aggressively double passes to either the full face or regional areas, but done over single treatment. So you can kind of tailor this to your patients, to all the way down to the non-facial areas, which is lower energies, and a single treatment. So you can kind of pick and choose as you want, depending on the patient and depending on what you're trying to treat. So where that fits into the spectrum is if CO2 laser resurfacing is out here with all of its issues, that doesn't negate the fact that it works with all of its issues, and erbium is somewhere over here. You've got your PSR3, which is roughly 3.5 joules, which is clearly better than erbium. Gives you some downtime. It gives you great procedure, great results with 1 treatment. Down to PSR1, which is that method where we use 1 joule over 3 treatments, get great results, no downtime, to very low I got your head there, Zach. To very low energy, which is the 0.5 joules, which is the lunchtime procedure. So in all cases, no ablation of the epidermis, and you sort of decide what you're trying to do. So you've got pretty easy recovery because there's no open wound. It is a non-ablative procedure, as I said. It doesn't take very long. It can easily be combined with other treatments. As I said, topical anesthetic is generally what we do, although you can use some regional blocks. You've got great skin quality without textural changes and delayed hypopigmentation. And because it's not a laser or light source, you don't need to use any special eyewear or do anything special in the room, which means in our office people just literally come in and out as we're doing it, and that's just fine. So how do we compare it to other modalities? And this is not meant to sort of say other modalities don't work, because we all do these things, and they all do work. But if you want to compare plasma to fractional lasers, you've got a single treatment here. You don't have to do it over multiple treatments as we see with fractional lasers. There's little to no downtime depending on how aggressive you are. You can treat regionally, a shorter overall procedure time. It can clearly be effective on moderate to deep wrinkles, being more aggressive with portrait, which generally, as you get to deep wrinkles, at least in my hands, fractional lasers are not that great at. You can clearly get demonstrable skin tightening, and as I said, you can use this for cosmetic purposes, medical purposes, and no eyewear or special preparation required. You can actually do this in conjunction with radiofrequency if you want to have even more skin tightening. But if you compare it to radiofrequency, it's a clearly shorter procedure time. It is a non-contact procedure, and as I said, you can get skin tightening at the higher energies. If you compare it to an erbium laser, it's clearly going to work better than an erbium laser, and again, without that degree of wound, and no special eyewear is required. So this is low energy, PSR1, basically 1 joule, done over, you can see 3 treatments, and then you can see the results 90 days after that. High energy, a single treatment. Within 30 days, really almost no erythema at all. Sort of a Botox-like effect if you use high energy on the forehead. Single treatment. You can do this regionally without zones of demarcation, as you can see here. Again, this is PSR2, so different treatment parameters depending on what you're trying to do. Again, here you can see before, and look at this at almost a year and a half later, the improvement there. Pretty much I find that the only things that will work on upper lips, if you want to get results like this, are either CO2 laser resurfacing or a portrait. And you can see the results there in terms of upper lip. High energy, single regional treatment, no zones of demarcation, 5 months post a single treatment. Again, this is PSR3, so it's roughly 3.5 joules. High energy single treatment and a year post treatment. Here you can see high energy single treatment, 3 weeks post treatment. And then you can do it off the face by using lower energy, and you don't have to worry about some of the problems we saw with CO2 laser resurfacing. Non-facial single treatment, and you can just see how this plays out. Very nice result. Non-facial single treatment as well. Non-facial single treatment off many different areas of the body. And again, non-facial single treatment on the hands. This is that low energy, that 1 joule. So this is now being done generally over several treatments. Here you can see only a single treatment and what it's done. And it can be combined, as I said, with other treatment modalities. So if you want to have overall skin improvement, some tightening, use Portrait with a PDL if you want to have impact on the redness. Here you can see it being done with Thermage. Generally what's done is we'll do Portrait one day and the next day Thermage treatment, and you'll get even that much more skin tightening of the skin, as is done here. And here you can see sort of the facelift effect, simply doing Portrait with the overall global resurfacing and the tremendous improvement in the skin. So in summary, plasma skin regeneration, or PSR technology, offers a bunch of different treatment options that you can pretty much match with both yours and patients' expectations. You can induce collagen remodeling in a very different manner than what we're used to, while at the same time promote skin tightening. And you can reduce wrinkles, tighten skin, improve skin tone, texture, pigmentation. Take your pick. It does it all. And that completes this talk.
Thank you very much, David. Yeah, you've got a great faculty tonight, I got to say, and David, with his great overview here, is going to be followed by Jeffrey Dover, Chestnut Hill Group, who's, again, he and his colleagues have had so much experience with pretty much every device out there, and you know, some work really well, others don't. So what we're going to hear now from Jeffrey is a review of lower energies performed on a more frequent basis, and I'm really excited to hear the results here, particularly the long-term results. Jeffrey?
Thanks, Christopher. Let me see. Maybe someone here can put my slides up.
I'm the man. I'm the man.
What a host.
I'm the man. Yeah, that's right.
Well, while Chris is getting that ready, I'll just echo David's remarks. I think what makes this technology unique is how versatile it is, because you can dial in the results you want from what I call level 0 up to level 3, or you can say from 1 to 4. But you can do what we're going to show you, which is very low energy technology or technique, all the way up to very high and anywhere in between. And I think it makes a nice device. If you want to have one device that does a lot of things, this is one of the devices that does that. Ken and I have been involved with a study that's almost done on what's called very low energy plasma technology. And let me just go back a bit. Eric Bernstein, who some of you know, a dermatologist from Pennsylvania, did a study to try to see whether or not, if you treated really gently, like more gently than the device is planned to be used, would it actually make skin look better? And he wanted to do a procedure that was painless, that was really quick, and had no downtime. And so he did this energy he called very low energy study. And in fact, it was presented at the Academy this past year. They looked at skin texture, fine lines, wrinkles, and pigmentation. And basically, what they found was very high patient satisfaction. 11 out of 12 patients would recommend this to their friends. The treatment time was basically 10 minutes per procedure. Minimal discomfort. In fact, it was just a warm sensation, if anything. And patients had a bit of redness after the procedure, shown here. You can actually see the individual spots where the energy was at its peak. But basically, this lasts at the very most minutes to a couple of hours and dissipates. These are the results from Eric's study, and you've seen pictures like this a lot. But basically, there was improvement in the skin texture and color. So based on Eric's study, Rhytec approached us, and they approached Roy Geronimus and, of course, Eric, to see if we could do a 3-site study to more formalize, I guess, the results and to see, in fact, if this was a truly effective technique. Basically, a spacer was made, which I'll show you, so that we could reproduce the results or the technique exactly site to site and patient to patient. So this 20-millimeter standoff, a plastic standoff, was actually made for the tip, which I'll show you. And we treated a bunch of patients at each of the sites. This is the tip, which has actually been modified since then, because unfortunately early on the tip, these little prongs actually would break, and it just needed to be made a little bit more rigorous. I think it was made this way simply for the study, and I presume a production tip will actually be made. So in the study, we treated a bunch of patients. Dr. Bernstein treated 10 patients with a very low energy with cosmetic cream beforehand for an hour. Basically, he then treated 7 without the cream. We, Ken Arndt and I and our fellows, treated 10, and Dr. Geronimo treated a total of 0. The average treatment time was 6 minutes, so it was actually 4 minutes less than what Eric had done in his pilot study. The average number of pulses, which was predicted to be 300, was 298, which is actually remarkable. The topical that was used was Emlyn. It was done 60 minutes prior. We did 6 treatments, each treatment done, and then wait 3 weeks before the next treatment. And then we evaluated the patients, a blinded observer that is. Patients were asked a whole bunch of questions. We took Vizia pictures in some of the patients. So this is actually the most important slide, I believe. Physician assessments. The downtime, basically, one patient had flaking on day treatment 2 for 1 day, but most patients had absolutely no side effects whatsoever. And on a wrinkle severity scale that my esteemed colleague, Dr. Fitzpatrick, derived and described a few years ago, from 0 to 9, basically the patients went from 4.12 to 3.94 30 days later if they just had PSR treatment. If they had PSR plus cream, they seemed, for whatever reason, to have worse wrinkles to start with than the other group, and they improved a little bit more. But all patients improved from 4.33 to 4.0. So it's not a dramatic change, but it's a change in the right direction. Nobody had pigmentation problems, either hyper or hypopigmentation. If you look graphically, which I think shows it a bit better, you can see that the PSR plus the cream in advance of treatment got the biggest drop in, or biggest improvement. And all patients, you see that it's not just a trend. Clearly, patients look better after they did than before. Keep in mind, these are 30-day data, and we're now waiting for the 90-day follow-up data to be analyzed. All the patients were asked to come back 2 months afterwards to see what we could get. If we look at patient assessments, basically, the patients thought that the technique or treatment helped their skin. I'm going to skip this because there's a lot of information there, but I'll show you here. The overall skin quality of the patients actually improved. Here's the patient satisfaction. If you look at the data, all the patients through the 30-day treatment, that is 27 patients in total, if you look, our scale is 0 is not satisfied and 4 is ecstasy. We had an average of about 2.48. In other words, patients were either moderately satisfied or satisfied. And just like what the physicians found, the patients found that if you did PSR after cream, there was a better degree of improvement according to the patients as well. And they, of course, didn't know what the doctors thought because the blind observer scored them without ever telling them their results. I was the blind observer in our center for the most part. And, of course, they never knew my score. So it's nice to know that both the patients' and doctors' results correlated quite well. Here's some very high-quality photographs, and I'll just go through these relatively quickly, mostly from our site, but some from Dr. Bernstein's site as well. I think for the most part, you can see that the picture on the right looks better than the picture on the left. The patients who show the most visible change have dyspigmentation as well as wrinkles. Those who just have wrinkles are harder to show photographic improvement. And I'll show you the next few. You can look in these areas that have been circled by the computer. They do have a better look to the texture of skin and to the color of the hyperpigmented areas in each of these. And I think the texture of the skin looks modestly better. Not nearly what David showed in those PSR3s where he treats very aggressively from 3 to 4 joules. Remember, this is only ½ a joule per treatment, a warm feeling. Patients that I treat where I do this outside of the study go right back to work. There's absolutely no downtime whatsoever. And I think this is a nice picture. Could just be the photograph and the flash, but I do believe that the skin looks brighter and actually looks better, so you can see why the patient would score themselves better after this series of treatments. So the conclusions are the patients rated their improvement 38%, and if they used cosmetic cream before, the rating was 44% improvement. It's a fast treatment. There's little or no downtime. It barely hurts at all. There were no side effects. And the patients noted improvement specifically in tone, texture, and quality of skin. And as I mentioned before, we're really going to look at the 90-day data to see if there's continued improvement after 2 more months. And I think I may just close here and just to say that we're waiting for the analysis of the Primos data. And I think we'll open it either for questions or comments from Ken.
I just add that this isn't a lunchtime procedure, it's a coffee break procedure. and it's before you got the coffee, because the average time was 8 minutes. It's quick, it's easy, it brings about modest results. You can do it on several occasions. Patients like it, and it shows the versatility of this very unique energy delivery system.
Hey guys, that's very nice. Thank you very much. Ricardo?
Yeah, we will have time for questions at the end for everyone. But as Chris was saying, we do have a very distinguished faculty. Our next speaker is going to be Brian Beisman. Brian is an ophthalmologist who's very expert at cosmetic procedures and very experienced with lasers, and the go-to guy if you have a new device you want to use on eyelids. So we'll be finding out what Brian found.
Well, good afternoon, everyone. Thank you very much. It really is a privilege and an honor for me to be here at the ASDS. It's a meeting which is full of a lot of friends, old friends and new friends as well, and I learned so much when I hang out with you guys. So it's really a privilege to be here. So as Fitz had mentioned, we're looking at plasma on the eyelids, and we're all familiar with the CO2, good side and bad side. So the question really was, can you use plasma on the eyelids to hopefully get a CO2 type or substantial improvement in skin quality with tightening and ridded reduction without some of the downsides of CO2. Now, I'm going to try to kind of give you an overview of what we've done is 2 studies. We started off, here's a summary of my talk at the beginning. 2 studies, we started off treating more aggressively than we ought to have, decided to make some parameter changes and put ourselves into what I feel is a much better place. That's the summary. Let me take you through exactly what we did. Looked at patients who were a bit more wrinkled with more laxity than we would expect something like fractional resurfacing to be able to treat. I've done some studies with a number of different fractional resurfacing devices, and the patients who I selected for plasma treatment were those who I didn't really feel would benefit so much from fractional resurfacing because I didn't think that they would likely have enough improvement to really make it worth the while. I did not have fractional CO2 available at the time, so these were patients who had moderately severe wrinkling of their eyelids, average age 55 years. Took my first group of 20 patients, 4 of whom underwent blepharoplasty only. We took the excised skin, we did some ex vivo treatments, and really had 16 patients. Divided them into 2 groups. Both groups were treated with the PSR3 protocol that David Goldberg referred to, with a energy setting of 3 joules. So one group of 8 patients had 3 joule single pass. One group of 8 patients had 3 joule double pass. So 16 patients, 2 groups, both treated at high energy, one group with double pass, one group with single pass. Treated with topical anesthesia only, used plastic corneoscleral lenses, assessed for degree of epithelialization, pigmentary change, erythema, scarring, and excess tissue in the upper and lower lids. Patients assessed themselves for discomfort, tolerability, skin texture, erythema, and satisfaction. Forget about all the busyness. Let me summarize these slides by saying when it came to reduction of excess upper eyelid tissue, average improvement for all groups was about 2.35 on a 0 to 4 scale. That was pretty good. If you convert that to percentage, about 20 to 25% improvement as compared to 90+% for blepharoplasty. Why wasn't blepharoplasty 100% improvement? I wasn't quite as aggressive as I could have been on the bleph, so I could have probably taken a little bit more skin in a few patients. So 20 to 25% reduction of excess upper eyelid skin. And that's, for any non-invasive device, that's pretty darn good. What about wrinkle severity? All comers, 35% improvement. So I think it's safe to say we saw a nice improvement in excess skin, nice improvement in wrinkle reduction. If you ask the patients what did they think, they thought that they had between 35 and 90% improvement. Again, pretty good numbers. Patients thought their skin texture had improved. This is where we started to get hung up. So far, everything sounds great, but there's a rub. The recovery time was long. With the double pass technique, you're looking at 13 days till patients felt like they could comfortably put on makeup, which in my opinion was too long. Even with the single pass, the higher energies, it was about 11 and a half days till patient. The question was, when did you feel like your eyelids were back to a baseline state where you could put on makeup and be comfortable? And in my opinion, 11 and 13 days was too long a period of time. On top of that, amongst the patients who received the more aggressive double pass treatment, 8 patients received that treatment. 2 of those 8 ended up with prolonged erythema and some textural change to the skin. I've got some photographs to show you. This is upper lid only single pass. You can see some improvement, fairly dramatic improvement in upper eyelid tightening. This was less dramatic tightening, but certainly some improvement. You can see these patients are older. I live in a state where there's a lot of sun exposure, so a lot of sun damage in these patients. Some tightening in the upper lids, difficult to see with the lights, but some in the lowers as well. Upper lid tightening, more dramatic upper lid tightening. But here, could we bring the lights down in front a little bit, please? I'd like to show this. Is there someone who can control that? Because what you're seeing on the left lower lid is an area of pigmentary change slash textural change, which was really a scar. It wasn't a big, thick, hypertrophic scar, but there was clearly some scarring present. It did ultimately respond to vascular laser treatments. But I went back to Rhytec and I said, look, you've got a treatment where efficacy was good, but I don't feel comfortable with the length of recovery and the fact that in the higher treatment group, 25% of the patients had some significant issues. And to their credit, I think Rhytec has done a great job in the way they've approached this. They didn't just say, oh, well, we're going to bury that data. We're not going to talk about the data here. They said, okay, let's go ahead and make some changes. We're going to make 2 changes. And ideally, it would have been nice to not change 2 different parameters. But I was using, you heard Jeff Dover tell you that to treat an entire face, he used 300 pulses. We were using about between 60 and 70 pulses per side in treating the periorbital region, upper and lower lids, and crow's feet region. So our density, I think, was too high, was part of it, and I wanted to back down on the energy. So what we undertook was a second protocol, which we're in the midst of now. I'm midway through. I've treated most of the patients, and I've got follow-up on a little bit more than half. We lowered the density, lowered the energy. When I say lowered the density, I went from, rather than using 60 to 70 pulses per side, with each pass we're now doing 25 to 30. So probably reduced my pulse count by around 2/3 or so, and also lowered the energy. We have 2 different protocols, again, a double pass at lower energy and a triple pass, lower energy, lower density, and now I can say I'm very, very enthusiastic about the changes that we're seeing. Very nice recovery, easy for the patients, just a few days, typically 3 to 5 days. Patient satisfaction seems to be high. Wrinkle reduction, skin texture, overall improvement does not seem to be dramatically less than we saw previously. Now, we're not done tabulating the data. I won't know until everything is in and assessed from a statistical standpoint as well as from a patient satisfaction standpoint. But it seems like backing down on the energy, backing down on the density, and my using surgical loops during the treatment so I can actually see the tissue change has made the plasma treatment of the eyelids really a very viable and I think a very exciting technique that can really play a nice role in an aesthetic practice. Thanks for your time.
Thanks, Brian. I think you're hearing the honest truth here, and I must say it makes it's a treat just to come up and listen to this. We're going to move on now. Rick, could you introduce our next speaker?
Yes, so our next speaker is going to be Dr. Ubelhauer, who has conducted a study regarding treatment of acne scars performed at the U.S. Navy Hospital in San Diego.
Thanks, Fitz. Appreciate that. We did a I am in the Navy. Just have to disclose that my ideas are not necessarily the government's ideas, but nevertheless, I am the representative laser surgeon. But anyway, so we did this study with the portrait for acne scars, and found that it improved acne scars safely, effectively, even at with high energy settings. Now, anybody who does treats acne scars knows that it often requires multiple modalities to get an optimal result. And one of the difficulties with acne scars is patients' expectations. They're often expecting more than you can provide. And I just want to add this small analogy. This was me when I was starting flight surgeon training in the Navy. I was excited, young whippersnapper, happy, ready to go, and I wanted to make it to fly with these guys, the Blue Angels. You know, the kind of the rock star lifestyle, going city to city, rock star parking, all that type of thing. But I didn't quite get that. I got sent to a tiny island off the coast of China and got to fly these that are called frogs. So anyway, it's a good analogy because the same type of thing happens with acne scarring and patients. They think that they are going to get this incredible Blue Angel type result, and they often end up with an improved result, but it may be the frog. And again, I enjoyed working with these guys a lot, but it wasn't quite the Blue Angels. And even with deep ablative CO2 resurfacing, which I've done a lot of, and erbium resurfacing, you still often can get a result that's improved, but not necessarily optimal, especially with a single device. The problem with deep ablative treatment is that you can end up getting this, and you may not be able to see this too well, but this is a patient that I've been working on for 2 years that was treated by another physician who wasn't familiar with the CO2 and gave her permanent hypopigmented and hypertrophic scarring. So in the wrong hands, CO2 and erbium deep ablation can be a big problem. Well, in 2004 in the UK, they did a pilot study with the portrait and found that using high settings, you could actually get an improvement in acne scars. This was followed by a gentleman down in Brazil who was able to show similar improvements. Here's a UV photograph of his results. And so working off this, we took 3 sites, 10 patients at each site, and used a single treatment, double pass, high energy, and evaluated them through 6 months. Their post-treatment care was essentially cool compresses, Aquaphor, Vaseline. We did use HSV prophylaxis as well. At our 3 sites, we did physician evaluations, patient questionnaires. We used photography and attempted to use some silicone molds. And the details, the treatment details were a little bit different from site to site as far as fluents. In Santa Monica, Dr. Lask used 3 joule double passes in all of his patients. Up in Montreal, they used 3 to 4 joules per pass. At our site in San Diego, we used 3.5 joules on the first pass and 4 joules on the second pass, with no overlap within each pass. This was the most aggressive treatment of any of the sites. I think we actually probably had the best results at our site. But anyway, overall of all 3 sites, the 6-month physician-rated improvement was in the low 30 percentile for the cheeks and then less for the chin and forehead. And pretty much everyone was done peeling by day 14. Most people were done peeling by day 7 or 8. Some were done at day 5. But again, there was one patient that did have some peeling at day 14. Erythema, for the most part, by 1 month was completely absent. Patients rated their improvement as smoothening of the skin, and felt that at 3 months they had about a 37% improvement in scarring, and at 6 months a little bit lower, which I think goes along with the whole expectations as patients continue to look at the scars that they still have. They tend to be less satisfied as time goes on. However, our photographs show that at 6 months This is with Dr. Lask. We did get a better improvement as time went on. Here, this is one of my patients. You can see at 3 months, improvement in pretty severe acne scarring. And then at 6 months, a little bit more improvement. And again, another one of my patients with bad pitted scarring, getting a modest improvement, certainly some smoothening of the skin at 6 months. Here's a patient who actually had a nice photofacial rejuvenation result with a lot less lentigines and freckling following the treatment, with, again, a modest improvement in some of her ice pick and boxcar type scars. And this patient with some mild acne scarring with, again, a modest improvement. This is a patient outside of the study, Hispanic type 4 skin patient that I treated with these settings. Treated her actually twice and found that she actually had an even better result with 2 treatments. So in conclusion, the acne scar study from all 3 sites demonstrated that it was safe, it was effective, and significantly effective. Hyper and hypopigmentation was not an issue. Like the other folks have said before me here, if you treat at these levels, you will have some patients that can get blistering or other problems, but certainly I never had any persistent hyper or hypopigmentation. 71% of the patients would refer this type of a procedure to a friend. And again, the patients rated their improvement at 34%. The mean physician rated improvement was less at 28%. At our site, I had a blinded dermatologist, been working with acne scars for 7 years. He wasn't blind, but he blinded, obviously, a blinded assessor. And he assessed the best side of each patient's face, and we came out with an average of almost 41% improvement, which was pretty significant with our aggressive technique. Now, in real life, this is a patient that I treated, another Hispanic Marine that I treated with 2 treatments, followed by 2 treatments with microdroplet silicone. And she's ecstatic. She's had an excellent result. You can see up on her malar cheek there a little bit of boxcar and pitted scars that haven't responded well, but for the most part, the rest of her acne scars did very well. This is another gentleman, a Marine, who lifted a booby trap device in Iraq and actually lost his arm from the explosion and had a lot of trauma to the face. We've done tattoo, the traumatic tattoo we've treated with the Q-switch lasers. We've used pulse dye to improve the redness, and we're going to use plasma then to try and smoothen some of the textural changes that he's had.
Thank you, Chris. So what I'd like to do is just go through a few items. One is looking at complications of plasma versus CO2 laser. And what we did was looked at published reviews of CO2 resurfacing. And then Dr. Rothaus and I looked at our patients over the past 2 years, and we're looking particularly at the instance of hypopigmentation, hyperpigmentation, persistent erythema, scarring, and infection. From the literature, with the CO2 laser, hyperpigmentation occurs in 20 to 30% or so. In our patients, we didn't have any patients who had persistent hyperpigmentation. In our 120 patients, we had an incidence of 4% of transient hyperpigmentation. Bacterial and viral infection occur in 7 to 8% of CO2 laser resurfacing. We didn't have, we had one patient who had herpes virus, herpes simplex, who had not been given prophylactic treatment. And we had a few, 3 or 4 cases who had isolated spots that looked like where they had been scratching themselves, about fingernail-sized spots that were culture positive. But in this group of patients, we didn't have any patients who had overall bacterial or viral infections. No prolonged erythema in our group. And the thing that scares people away from the CO2 laser primarily is the fear of late hypopigmentation. And I think this number from the literature in the 8 to 20% range is pretty accurate. And I really don't understand a lot of why that happens. I know sometimes it is related to treating too aggressively, sometimes it's related to scarring, but sometimes it happens without explanation. So far, not only in our patients, but in all the patients that have been treated with the portrait, there's not been a single case that I have seen that I've been aware of that has had hypopigmentation. We had one patient in our group who had a spot of scarring secondary to where she had scratched or picked a spot on her skin, but it was about 3 or 4 millimeters in diameter. And I think the scarring rate in CO2 laser resurfacing is around 1% in most series. So and the average recovery time was less than 7 days. So this is a very safe, well-tolerated procedure, as you've seen from the other presentations. And having done this for a number of years, I have evolved into doing a little more aggressive treatment than average. And this has evolved in 2 ways. One is using a double pass technique, although it's not truly 2 passes over the whole skin surface. Typically, using this approach, I will use about 1,200 pulses, which is 1 tip. Of those 1,200 pulses, I'll put down 800 pulses in the first pass and about 400 pulses in the second pass. The second pass I use primarily to fill in areas that haven't reacted as significantly as the rest of the skin. And if you do this procedure, you'll find that for reasons that I don't quite understand, but there are spots that even though you hit them with the same temperature, same spot size, there may be differences in the stratum corneum, differences in hydration, some subtle differences that so you don't see the same changes. So those are the spots where I would tend to go back over more significantly. And with this technique, I would use 3.5 joules or 4 joules, including the eyelids. We treated at 3.5 or 4 joules. This first treatment technique is without overlap, and I was very careful not to overlap, treating at 1 hertz or 1.5 hertz. The second treatment technique, which was developed more by my associate, Bill Groff, was using an overlap technique, overlapping 20 to 30% and treating at 2 to 2.5 hertz. Now, if you treat at 2 to 2.5 hertz with 30% overlap, you have to be careful not to get bulk heating. If you are treating in a small area, you're going to have significantly more heating of the dermis. So in using that technique, you want to have wide ranges that you're going over. But I've used it. It does work safely if you are experienced in doing that. And with that technique, typically on my patients, I would treat around 1,500 pulses. So an extra 200 or 300 pulses over what I would use with the first technique. On all of our patients, we use nerve blocks. We use topical anesthetic, 23% lidocaine, 7% tetracaine. We give them antibiotic coverage. We also give them Valtrex and diflucan. And we give them either PO, Valium, or IM, Demerol, and Vistaril. And most of the time, we also give them a shot of 6 milligrams of dexamethasone. and we treat with vinegar soaks. Now here's a patient who's immediately after treatment, 1 day and 2 days. Usually the treatment on the far right is actually 2 days, not 3 days. And usually 2 days is the day of maximum swelling and discoloration. And then the epidermis starts to peel, and you'll get, generally, the peeling is finished by 6 or 7 days. And I think that's the really nice thing about this procedure, is it heals like a TCA peel, but you get results like a CO2 laser peel. So this is one of my early patients, and you can see around her eyelids, she has some very nice tightening, nice overall rejuvenation of her facial skin. And she had this improvement in her eyelids. It was interesting because it took 3 months for this to develop. At 1 month post-op, she really didn't have much tightening at all. And I find that to be true with this technique. And I think that's an indication, a very good indication, that the improvement is secondary to new collagen formation and not secondary to edema. Here's another patient who is actually one of our nurses, and you can see these fine lines she has around her eyes, and they're virtually gone. This photograph was at about 6 months post-op. She's now over a year post-op, and she still doesn't have recurrence of these lines. So she had very, very nice rejuvenation of her facial sun damage. This is the same patient from the other side, but you can see that very nice rejuvenation around the eyes. And if Brian is still here, I don't know if he is, but she was treated at 4 joules on her eyelids. And I have found that the high energy treatments, high pulse energy treatments work great on the eyelids. This is another. Pretty close to what you were doing. Probably, actually maybe a little bit more. Probably around 50 pulses per side, around 100 overall. Yeah. And this is another lady who has this same double pass technique, about 1,200 pulses over her whole face, 4 joules. Really excellent results around her eyes. And I find that the eyelid area is the area that responds most predictably. You can see up close, the nice improvement that she has there. This lady is featured in some of their advertisements, but she had incredible tightening along her jawline, and look at her neck. I mean, this is all from, and on her neck, I think I was treating at, 3 joules. Actually, at this time, I was treating the upper neck at 3, and then I dropped down to 2 on the lower neck. But again, 2 passes, and very nice rejuvenation of her skin overall. Here's this area along her jawline. And then these are some of Bill Groff's patients who are treated with this overlap technique. And I think that the results are excellent. As far as pigment, as far as improvement around the eyes, if you look at this tightening that she has there, and I think maybe around the eyes that these patients actually do a little better than the no overlap technique. This young lady who's got, I'm not this looks like melasma. I'm not sure if this is photo damage or melasma, but sure looks like melasma, and she got a very nice result there. And excellent results around the eyes again. And this is a patient, one of the early patients I treated, who wanted to have these lines around her mouth treated, but she wanted me to treat her with Fraxel. I was afraid Fraxel wasn't going to do much to these lines, so I combined Fraxel and Portrait. So I did Portrait around her mouth and Fraxel on the rest of her face. And look at these nasolabial folds, how they responded. But all these lines responded tremendously well around their mouth. And so that's kind of an overview of using a more aggressive treatment approach. And these are some exciting new slides using a new pulse delivery system that is top secret, and I can't go into that. But there's some exciting results here. So this is immediately after treatment. This is the zone of thermal damage, and this is where it's going to cleave. And then this is the area of thermal modification, and this is where all the action is with this device, is in this thermal modification zone. So this area that's crusted, this is where it's going to slough, and then the new epidermis is regenerating right under the crust. And it will gradually develop a new stratum corneum, but it's also developing new healthy collagen in this area. So this early phase of collagen remodeling of the dermis results in a flat epidermal-dermal interface. And as this continues, we see more significant neocollagenesis, and then we start to see some formation of reedy ridges occurring with the new epidermis. And this is about, what, 2 weeks? 8 days out. 8 days out. This is in a pig study. And look at these reedy ridges that are forming here. I mean, this is very dramatic. I mean, that is so different from anything I've ever seen before that it's astounding. And then here is 12 days, I believe, right? At the same time. Okay, and there's new vascular formation occurring as well as neocollagenesis and new elastic tissue staining seen in these in this healing area. So this is really a exciting new histology for this. But this is using a little bit different pulse delivery than we have been using up to this time, but it does give us some indication of things to come. And now we will have our most expert speaker, Dr. Chris Zachary, who will tell us something about the British approach.
I don't know if that's good or bad, Fitz, but I will indeed tell you about the British approach, which I guess is appropriate since this, was this not the first British device? Okay, disclosures. I've had educational support and loan of equipment for observational studies from Rhytec, and I appreciate it. I'm going to spend 2 minutes because, the important part of tonight is actually the discussion coming up. So I'm just going to very briefly remind everybody that Haley can be dramatically improved using destructive techniques. This happens to be the groin of a patient who suffered all her life with Haley. I was doing little test patches with CO2 and with erbium YAG, and when she came back 2 weeks later, we actually did another erbium YAG pass here. But this area is about 2 weeks old, and this fresh new skin was for years and years afterwards without any problems. So I wanted to see what would happen with this device in this lady who had the worst Haley. She also had a lot of other problems. She had widespread psoriatic keratosis and what have you. But basically, we treated this entire patch. I'm sorry I don't have a preoperative photograph. But I just want to say this entire patch has improved. Not surprising. This is a destructive technique, and I think we were pretty aggressive in this area. So what I'd like to say is that you've heard all the cosmetic applications. There are medical applications here. Think of all your children. Not that you have a lot of them with XP, but I think children with XP deserve a treatment maybe once a month, or our transplant populations. Maybe they should come in every month for a superficial treatment. I mean, there are so many really good indications for this in terms of prophylaxis. This is a patient, as you can see, with linear porokeratosis. on the ankle and the foot, for instance. This is after one treatment, and there's been some improvement here. It was very keratotic originally, again, preoperatively on the chest, same patient, linear porokeratosis. We did different fluences with 1, 2, 3, and 4 joules, etc., and you can see an obvious response here. Subsequently, this is the healing at about 1 week. When these have healed up pretty well, still red, still some inflammation. And indeed, this patient could get some textural change here. But if it actually results in a reduction, a permanent reduction, this is 1 week later, and it's still a little bit shiny, etc., in that photograph. Not great focus here, but here she is about 2 or 3 weeks later, post-operative, post-inflammatory hyperpigmentation, all that sort of stuff. But she's actually happier because her symptoms are better, less itching, and so forth. Though, what's the chance of this coming back? I'd say very high. But anyway, just to show you, there are medical indications here. Okay, I'm going to stop now, and we're going to move to a question time. And I'm sure if the panelists are still here, I want to ask 1 or 2 questions. If you wouldn't mind just coming up to the front and grabbing a microphone here. I'm going to ask my colleagues out here, so why is this any different, whether it's better or not better, than a single-pass CO2? I'm going to ask you that in just a few minutes, because it's critical that we should know, for those of us who've got other resurfacing devices, should we go out and actually buy this, or is there something actually specifically better? Yes, please, Peter.
Yeah. Fitz, I'm finally impressed with some of these pictures on acne scars. It's hard to, I'm used to doing the modified phenylchemobration technique for acne scars, and it takes a lot of work. And I'm seeing some pretty impressive pictures with the plasma, sometimes with the Fraxel, but how to explain the beneficial effect on acne scars that we weren't seeing with the CO2 laser before? Is it the heat? What's happening
well,
down there?
That's my understanding of it anyway. One of the things about this device that was unexpected by me was the degree of collagen remodeling that occurs. And from thermal modeling, it's estimated that this collagen remodeling process from heating of the dermis goes down 500 or 600 microns. And that's significant depth, particularly for acne scars. And I think to make acne scars better, you've got to get down that low.
And I think it's also the textural change, and with the phenols you actually liquefy and the skin, and I guess you're doing something similar with the plasma?
Well, not in the dermis, only the epidermis.
We're going to finish in 2 minutes, but I just want to address this question because originally when I heard about plasma kinetic energy, I simply didn't see any difference between this and the very precise erbium YAG laser resurfacing that I was doing day in, day out. But I, in fact, in practice, do believe there is a huge difference, and I think the main difference is the fact that the patients walk out with some redness and swelling, and they have this extraordinary natural dressing on, and they, as far as I can tell, do not get problems with post-inflammatory hyperpigmentation, delayed onset, permanent loss of pigmentation, or scarring with appropriate parameters. But I would still ask the question, how does this differ? And I'm going to ask Ken Arndt this. Ken, how would this differ from a single-pass CO2 laser in terms of efficacy and in terms of the patient assessment and so forth? Is it pretty much the same, or is this a different animal?
Well, the fact you have a desiccated, dry membrane with no oozing, basically no wound care, I think it's probably a little faster, and I think the patient would have greater acceptance. And as far as efficacy, I guess it depends on how intense the single-pass CO2 was, but I think it should be close. I think it'd be easier.
Yeah, I mean, I think this is one of the big differences, frankly. This is an extremely, dare I say it, simple device to use as long as you're appropriately trained. I think it's technically a lot easier than the CO2 laser. I think with a CO2 laser, there are all sorts of things that can go wrong. So this is why I like to use this on a regular basis, and why I'm quite happy to give this to my residents, for instance. Or for that matter, I'd be happy for my nurse practitioner, not that I have one, to use the same device. Last comments, Jeffrey?
No, I think what you just said is the most important, Chris, which is we have highly skilled fellows. These are board-certified dermatologists. They're of the best trained people in the country. but we don't hand things over to them very easily. And there's no way I hand them the ultrapulse and say, look, do the case. I'll be
Particularly for the
next door.
cosmetic patients, yeah.
But with
right.
this procedure, I mean, Dr. Christine Choi, she saw how to do it, and I said, okay, now go ahead, and she actually did it as well as I could.
Right.
And she's bright and highly skilled, but boom, boom, boom. And so you're right, it's way easier to use and I think more forgiving.
Yeah.
And as Ken pointed out, the wound care is a bit different. I think the results from what you and Fitz have shown are at least as good.
This is
Yeah.
striking that only part of the face was treated, because you
By
can
mistake.
see what it does, and you can probably get that result with more treatments with less fluence, and I think that would be one of the very nice things about this.
One last comment from the front, sir. Please go to the microphone.
How we can compare the plasma with the fractional CO2 laser?
Right, that's a great question, and I do know a bit about both. I think, in all honesty, I am going to be showing tomorrow and the next day some results with acne scarring and with wrinkling and skin tightening with the new CO2 laser parameters, the fractional CO2 laser parameters, which I think are quite interesting. Having said that, technically, the fractionated CO2 laser is much more complicated. There's a lot more downtime, and I think it's actually going to be a lot more, probably double the price to buy the device. It's a different animal, but I think you're going to see both these devices going to be employed. For those of us who have got quite a number of devices, I think many of us are going to have both, because as you've just heard, this is such a simple device, you get great results with it, and you're going to be using it on a regular basis. Fractional CO2 is something that we're just learning about, and I have to say I'm somewhat biased in favor for the acne scarring because we're seeing some pretty interesting results, but it's a much more technically difficult thing. Plus the patients have the downtime with that device.
When you see somebody with photo-weight skin, hyperpigmentation, when you see someone with acne scarring, and you have a Cyton laser, and you have this plasma technology, which is very exciting, and you have your next generation Fraxel, where do you, having all three capabilities, where do you use each?
This is a long, I'm going to make it very short. Basically, most of us are not going to have that. We're going to use what we have. But in practice, I think for the deeper scarring, frankly, I do believe that the fractionated CO2 laser is going to be king. I've stopped doing dermabrasion, and I'm going to stop doing CO2 and erbium YAG laser for acne scarring because of that. However, as I've said, this is a device that is so simple to use and so effective and with so minimal patient downtime that I think there are many patients who will choose this. I think what we do is we give these patients a menu, and they say, well, I prefer less downtime and maybe less efficacy in terms of the deep scarring associated with acne. With that, I'd like to thank our faculty. It's been a wonderful evening and discussion.